So good morning everyone, and thank you for joining us today for our 9th webinar in our series. Today's webinar is about supporting recovery and adapting to new pressures. So we're going to give everyone a moment just to join us. Please let us know in the chat where you're joining us from. It's always nice to see the range of people and where you're coming from today. I think we'll get started. So good morning to those of you that have just joined us. Today's webinar is around MAT standards, and it is supporting recovery, adapting to new pressures, and it's our webinar 9 in our series, which is great. So thank you so much for taking time out your very busy day. I really appreciate how complex and busy things are in the system at the minute, so I understand taking time out to attend a webinar of this nature is a big ask, so thank you so much for doing that. We've got a few minutes, so we're just going to, I'll give you some housekeeping and some inside information whilst we allow colleagues to join us. And please use the chat to tell us where you're joining us from today. It's good to see the broad range of participants. We do ask that unless you're speaking, that you turn off your microphone and you turn off your camera. It just helps protect the bandwidth for speakers. And so we're going to launch a poll just in a wee minute, and we're really keen to understand the capacity that you're joining us and to understand your interest in joining us. It just helps us prepare our webinars and make sure that for whatever subject matter we're putting on is actually of value and interest to the people who are participating. So thank you very much for joining us today. As I've said, before we get started, I just want to give you a little bit of general housekeeping for those of you who might not have been to webinars before or have participated previously in them. We do ask that unless you're speaking, we ask you to turn off your microphone and switch off your camera just to protect the bandwidth for everyone else. We will be using the chat function today, so please use that to post your comments, reflections or questions for speakers. We've got some fantastic speakers today, and we're really interested in how that information lands for you, and if you have any follow-up or any other additional questions that we perhaps could put to the speakers or actually ask them to kind of pick up offline. So please use the chat function. It's really good for us to see whether the speakers are helpful for you in your role or any sort of residual questions that you might have. If you've got any technical difficulties, we do ask that you email us, because we've got the team in the office who will just be able to pick up any of that and any requests to get any technical issues dealt with. And the email address for that is his.mat@nhs.scot, his.mat@nhs.scot. The team are in the background, so they'll pick up anything in relation to technical difficulties. You'll see today that we are recording, so the webinar will be available for you to share with your colleagues afterwards once we've finished recording today. Before we get into the subject matter, and please tell us, if you're just, for those of you that have just joined us, where you're joining from the chat, and there'll be a poll that will pop up on the screen. We'd just ask that you complete that as we go along. Before we get started with our speakers, it's important for me as the chair just to kind of give you a bit of a trigger warning. Today's content might have some personal experience in it, and it might talk about some difficult situations or subjects. And we realise that these can be harmful to individuals and they can be triggering or upsetting. So if you would, if you feel that way and you feel a bit upset, please look after yourself and leave, and let me know direct if there's anything that you think that we should do differently in the future. We are using the chat box, and the chat box is a public forum, so we do ask that you don't put anything of a private nature in the chat because it's publicly available, and that you don't put any personal situations in there. But all of our speakers will be treating the subject matter with the utmost respect. But just if you as an individual feel that triggered by any of that, please look after yourself and sort of leave, and I'm more than happy to have a conversation with you afterwards. So the poll that we've got on the screen at the moment is asking you about the capacity that you're joining and asking you about your interest in joining. It just helps us feedback and design our next sessions. So before I move on to our first speaker, if I can get them to put on this screen and open their mic, let me just give you a little bit of a brief context and a plan for today. So you'll see the agenda on the slide. Today's webinar is about supporting recovery and adapting to new pressures. You know, we hear a lot from the system and from recovery communities and individuals seeking recovery that the landscape's changing, substances are changing, how we respond to treatment and addiction is changing. And so we wanted to really give a safe space for us to talk about recovery and talk about the importance of adaptation to new demands in the system and how we should invest in recovery. And so you'll hear today from a range of speakers who are trying to kind of give you their different perspectives. So our first speaker today is Hazel Torrance. Hazel is the head of Forensic Toxicology Service with the Scottish Police Authority and is going to give you some really fascinating insights about the challenges in detecting new substances in the system and for people, and also what that means to our system of care. Following, and you'll have a chance to ask Hazel questions. Hazel has to dash off after her presentation. However, if there's any questions that you have for Hazel, please put them in the chat and we'll pick them up. If not, we can ask her to take them offline. After Hazel, we've got David McCartney. So Dr. David McCartney, he is the chair of the Scottish Government Residential Rehab Working Development Group, and he's also, within Health Improvement Scotland, one of our addiction subject matter experts. So David has a long history of understanding this subject area and has a real passion for recovery. So we'll hear from David. We should have a bit of a break in between times to let you sort of fill up your tea. And as I say, if there's any questions for anybody, we'll pick that up. Going into the second part of our session, we will then have James Docherty. So James Docherty, some of you may know, and is an advisory officer with the Community Justice Scotland and works with the Violence Reduction Unit. So he's going to come and chat to us about the importance of supporting people to recovery. Then towards the end, we're going to pick up any kind of residual questions from you guys as the audience, and we'll have an opportunity to sort of reflect on anything that we've heard throughout the day. At the end, there'll be a couple of polls that we'd ask you to complete before we finish off, and we're hoping to finish round about 12:30. So long as the next speaker can open their microphone and put their screen on, I will pass you over to Hazel. Are you there, Hazel?
I am, yes. Got my
That's
camera
great.
and
I'll pass
microphone
over.
on.
I'll pass you
Thank
to
you.
it. I'll come on when we're ready to move on.
Great, thank you very much. Thanks, Ruth, and thanks for inviting me to this webinar. It's a pleasure to talk to you all today. A massive range of people, which is great. Hopefully you'll find some interest in what I'm going to talk about. I don't know if any of you were at the SDF conference in Stirling earlier in the summer. But some of the slides might look a bit familiar, but I've updated them with some more information, so hopefully they'll be of
Hazel, can I just say, I don't think we can see you. I don't know if your camera, put your camera on.
My camera is on.
Okay, might just be taking a wee minute to go through to me.
Should be. It seems to be on from my point of view.
Thank you.
Alison can see me. So yeah, on to the slides. There's quite a few bits of information, so it might be a bit of a whirlwind tour, but like Ruth said, happy to take questions or for you to email me with questions. So I'm just going to present data that we have collated through our Post-Mortem Tox service, which we have done for the west of Scotland, certainly since forensic toxicology began in the 1960s. And we've been covering most of Scotland, apart from the very north, since 2013. So we've got a lot of data that covers any sudden, unexpected, unexplained death across Scotland. So I guess that's one of the main things to kind of caveat with the data that I'm going to present, is that the drug-related deaths are a subset of all the cases that we have. So it's about 45%. Obviously that kind of varies, you know, but thankfully we don't have many homicides. And so most of our cases are either drug-related deaths or they are natural or suicides. So these are cases that are unexpected, and so they are legally investigated by the Crown Office. So we'll get cases that will have drugs in them because people use a lot of drugs in a prescribed manner. So it's not necessarily that all of these drugs have killed people or, are part of the cause of death, just that they are in their system. So if we go on to the next slide, these are some of the challenges that we have when we're testing in post-mortem samples, and another kind of few caveats on the data that I'm going to present. So I'm sure many of you have seen real blood from live people, and that's quite different to the blood that we receive after somebody has died. Their post-mortem blood is really quite a different kind of substance, which makes it a challenge to analyse, for us to test, for us to extract out the drugs and put them on our fancy bits of equipment. So that's our first challenge. Our second challenge is the range of analytes or drugs that we want to test for. And as I'm sure many of you are aware, the number of prescribed drugs is hundreds, if not thousands, and they've all got a different chemical nature. So I'm a chemist by trade, not a medic, and I'm going to show you some chemical structures, but I'll keep that to a minimum. And obviously new drugs come on the market, are abused, but also are new to the prescribable market as well. So we need to keep on top of those changes. Availability of reference material is a big challenge for us, especially for new drugs. Reference material is something that we need to positively identify with a great deal of certainty, a new drug. And if that's not available, then it's difficult for us to report that. So for new drugs, this can sometimes be a bit of a challenge. And we also have a huge amount of validation of new test methods, a huge amount of regulation. So when there are new drugs to consider to test for, we can't just suddenly test for them just like that. There's a lot of regulation and documentation of things that we need to do to ensure that the results that we are reporting are valid and people can have faith in them. So we need to kind of understand these to make sure we're making the most of our data. So if we go into the next slide, and the next one, so what do we see in post-mortem toxicology? So this is a kind of very general list of the prevalence of drugs that we see in all of our deaths. So again, not just drug-related deaths. So mostly they are respiratory depressants, and that's a big concern when multiples of them are seen at the same time, which often they are. So cocaine is the one that sticks out, that is increasing in prevalence and is not a respiratory depressant. So the combination of respiratory depressants and cocaine, I don't think anybody's very clear on that interaction. So it's making the interpretation of the effects of the combination of drugs really quite difficult from a post-mortem point of view. But obviously these people are walking around, prior to them coming to us, and with that combination of drugs, so their general behaviour is difficult to predict, I guess. If we go on to the next slide. So the first lot of data I looked at was 6-MAM and morphine. So 6-MAM is short for 6-monoacetyl morphine, and it's the first metabolite or breakdown product of diamorphine, the active ingredient in heroin. So when we see 6-monoacetyl morphine, we know that that person has died relatively quickly after injecting the heroin. So if we don't see 6-MAM, then that would tend to suggest a more delayed mode of death. And I was looking at the prevalence of 6-MAM and noted that it was decreasing and has been kind of decreasing since 2020. And even though the prevalence of morphine is also decreasing, the difference, the 6-MAM seems to be decreasing more. So is that a symptom of a more delayed deaths and less acute deaths? I've just seen a question. We can't detect hemoglobin. We can search for carboxyhemoglobin, but we don't. We can kind of look for total hemoglobin, but post-mortem cells start to break up, and so the levels are not particularly accurate. So lots of things change when you die, and yeah, it's not always that useful to look for the same kind of biochemical things that you might look for in live patients. I was also looking at the median morphine concentrations and to see if there was more delayed deaths, then maybe the amount of morphine is reducing as well. And that would lend weight to that idea that there's more delayed deaths, and because you don't need the same concentration, the same high concentration of heroin to die, because you've got lots of other respiratory depressants on board. So it kind of looks like there's a decreasing trend in morphine concentrations in all our casework. So maybe it all fits together in that whole idea of less concentration required to have a fatal outcome. So when I talk about delayed deaths, I mean the time between the injection of heroin and when they actually die. So most of the time when people die of respiratory depressants, and we read this all the time in police reports, they'll take the drug and then maybe there's witnesses suggesting that they're snoring or they're sleeping. And so all that time they are metabolizing that drug. The drug is breaking down, but they are getting decreased oxygen into their system, and ultimately that's a fatal outcome, but it just takes a longer time as opposed to an acute take the drug and die very quickly. So we seem to be seeing more delayed deaths because there are more drugs on board, but it's a combination of those drugs that are lower concentrations rather than higher acute concentrations. So on to the next slide. Having a look at the benzos and the gabapentinoids. So this is over the last 10 years, we can see quite a change in the prevalence of these kind of group of drugs. So 10 years ago, we've got huge amounts of diazepam, and a combination of pregabalin and atizolam and gabapentin. But in 2023, that's changed quite significantly. So it's just plotting the changes of those. It's a lot more of a mixture as opposed to one dominant benzo type drug. Go on to the next slide. So another drug of increasing prevalence is cocaine, but the complicating factor of cocaine is that there seems to be increased purity of cocaine and increased amounts of injecting cocaine, and that seems to be shown in our statistics. I've looked at benzoylecgonine, which is the first metabolite of cocaine, and cocaine, like 6-MAM, almost breaks down really quickly. So if you're seeing, we often don't see cocaine, we see benzoylecgonine, but we seem to be seeing more cocaine in our casework, which is possibly a symptom of the increased purity of cocaine that people are using. Next slide. So I was looking at the cases that we see cocaine in, and you can see over 2012 to 2021, the increase in the ratio of female to males with cocaine in their system. So certainly there's more females using cocaine that we find in our fatalities. And looking at the age distribution as well, you can see in 2012, it's mainly the 21 to 30-year-olds. Over 50% of the positives were in that age group. And when we look closer to now, this only goes up to 2021, it's much more spread out. If you go into the next slide, it gives you a bit more detail. So it looks like there's a decreasing younger age group using cocaine, increasing in the older age group. Certainly the 51 to 60-year-olds seems to be steadily increasing from 2018 to 2021 there. So unfortunately, we've not got data for 22 and 23, or it's incomplete, but we'll be able to update that in 2024 when this year is out. Okay, next slide. So I was looking at, we seem to see more cocaine and heroin use, but the data seems a bit counterintuitive when I look at the ratio of cases that are positive for both benzoylecgonine, the metabolite of cocaine, and morphine, and benzoylecgonine on its own. So it kind of looks like there might be a decreasing trend in that ratio, even though the prevalence has gone up for both of them. But something to keep an eye on. Maybe it's not a great indicator because it doesn't feel like that. It feels like there is more cocaine and heroin. So we'll see if we can get more information about that. Next slide. One thing I have noticed is the increasing of detection of methamphetamine, which is a very unusual drug for us to see. And the numbers are still really tiny compared to a lot of the other drugs. I've just put that in context with MDMA and amphetamine. So it's possibly too early to tell, but something I think we need to be keeping an eye on is the methamphetamine detections. Next slide, please. The ketamine prevalence is an interesting one because, as I was suggesting earlier, some of our casework is from people who have died naturally, potentially in hospital, and they may be given ketamine. So we need to take these numbers with a pinch of salt. But there does seem to be potentially some increasing ketamine use. And I tried and caveat the ketamine that was maybe more illicit use rather than from hospital use. So looked at the number of ketamine plus benzoylecgonine, or the cocaine metabolite, and that does seem to be increasing somewhat. So small numbers, but worth keeping an eye on. I'm really aware of the time, Ruth, and I know I've got a few more slides, so I don't know if you want to cut me
Hazel.
off.
I can give you a couple extra minutes, don't worry.
Okay, I'll speed through. So next slide, please. So I thought I would give you a bit of an update on where we are with nitazines. They're obviously quite high in the media at the moment, and everybody's concerned about them. And that's understandable considering their potency. So I've been collating the numbers that we've had across Scotland, so both our lab and Duncan Stevens' lab in Aberdeen, and this is the latest kind of numbers that we have. Now, bearing in mind that these are the number of cases that are positive for a nitazine, so that doesn't mean that they're implicated in the cause of death necessarily, just that we've found them. So you can see that there's definite pockets and clusters of cases that are positive for different nitazines in different areas. So it's certainly something to keep an eye on. We had a bit of a spate earlier this year, but more recently we've not seen as many. Next slide, please. And xylazine, I've seen loads of headlines about xylazine, but really these are tiny amounts of cases that we're seeing positive for xylazine. So just be aware of the media surrounding this is not necessarily the reality of what we're seeing. So we're really not seeing many at all. And always with other drugs on board. Next slide, please. Last slide, my conclusions. So I think there are a few indicators that suggest polydrug use is really the main issue, which is not a surprise to anybody, I'm sure. But this is borne out by the data, I think, with a reduction in the 6-mam that we see and a reduction in the concentrations of morphine. The nitazines and the xylazines, although are all over the news, are really, really low prevalence. And it's something that we're keeping a close eye on, but they're not having a huge impact at the moment. There's definitely increasing cocaine prevalence, and that prevalence is more in females and older age groups. So not your typical, stereotypical situation of young males, and potentially the increase in concentrations that we find is due to that change over to injecting cocaine as opposed to snorting it, and the purity of the cocaine as well. And some things that we need to keep an eye on as well, including the nitazines and xylazine, is the potential increase in methamphetamine and ketamine use. So certainly a changing drug picture in use, and yeah, good to keep an eye on it all. So apologies for that rush through, but hopefully you got something from that.
Thank you so much, Hazel, and we can share slides to colleagues. Hazel's put her email address up there, and I know that you were saying earlier that you'd be happy to chat to colleagues if they've got any specific questions. Is that right?
Yeah, absolutely. Get in touch and come and see us as well.
Yes, I think our team might take you up on that opportunity. I've got a couple of questions, Hazel, if that's okay.
Yeah, no bother.
First question that popped up actually that I thought was quite helpful to understand is, what does delayed death mean?
Yeah, so I tried to answer that when I was talking, but basically most of the time when people die of heroin, or heroin being the primary cause, either people die acutely very quickly after a high concentration of heroin. So, you know, some people, or you might have heard of like dying like with the needle in their arm kind of thing. Or if you've already got other respiratory depressants on board, then maybe it doesn't require such a high concentration of heroin or a high dose of heroin to cause that fatality, and it works on you over a longer period of time. So an acute death would be within minutes, and a delayed death could be over a number of hours.
Okay, that's really helpful actually, thank you very much. And another question I've got here is about the role that you and your lab have around, so how do you and your lab meet the challenge around trying to ensure you avoid missing a new developing substance in toxicology samples?
Yeah, it's a constant challenge, and to be honest, when we were part of the European EMCDD, I don't know whatever that stands for, but a European network, and they would send these alerts out saying this new drug's been found and this new drug's been found in Hungary and whatever. I was concerned every day that we weren't potentially looking for these drugs, but it's really important to understand what's going on locally within Scotland and within the UK. And so it's great being within forensic services now. We've got access to all the drug seizures across Scotland, and we're a really small field, and we're quite chatty, so we do talk to each other quite a lot and share that information about what's around and what's pertinent to hear. The other thing is that we have two approaches to testing. So we have a targeted approach where we specify to the instrument exactly what it is that we want to look for. And we also have an untargeted approach for all our casework as well. So looking for unknowns, and that's where some things have popped up in the past. Xylazine, for example, that popped up in our unknown screen before we have added it to our targeted test. So we're pretty well set up, which is good.
Thank you very much, Hazel. I think the audience could probably ask you a number of questions, and there's some in the chat, but I'm just thoughtful of time. So we'll get them all tidied up for you and give them over to you, and perhaps you can maybe come back to us with some of your reflections and thoughts, if that's okay.
Yeah, absolutely. Happy to do that.
Thank you so much, Hazel, and thank you for such a interesting and reflective presentation. I really enjoyed that. David, can I just ask you to open up your camera and your microphone, and I'll pass over to you for your presentation.
Sure, both of them should be working. I don't know if you maybe can't see me, Ruth, but I can see myself and I'm looking wonderful.
Always. Thank you, David. I'll pass to you. Thanks.
Thanks, Ruth, and thanks. That was a great presentation, Hazel, and really interesting, and it actually fits in really well with some of the stuff I was going to reflect in this presentation. So just want to say thank you for the opportunity to present. Thanks to Ruth for the invitation. Some of you might know me. I've been an addiction doctor for exactly half of my career. The first half was spent in general practice in inner city Glasgow. So I've seen a lot of people with drug problems, alcohol and drug problems over the years in a variety of settings. I worked in the community as an addiction specialist as well. So, you know, an enormous amount of effort's gone into the work we're doing in Scotland to try to tackle our drug deaths problems. I know this because it has impacted on the teams that I work with and the community teams that referred into the service I worked in. But as we just heard, in light of the changing kind of presentations and drug use patterns, are there any blind spots that we're not addressing? And is our approach with the MAT standards missing anything, or is the emphasis in the right places? So just to reflect back, it fits in with what Hazel was saying. Next slide, please. On the changing patterns of drug use this is in the residential rehab setting, very specifically LEAP, which is a residential rehab in Edinburgh, which serves the Lothians. In 2006, when we launched the service, alcohol was the number one, and still is actually the number one problem drug that people present with. But in 2006, the second most common problem drug was opioids, and then followed by benzos and then cocaine. And the pattern of drug use at that time was much more towards the trend of single drug use. There was polydrug use at the time, but not nearly to the extent we see these days. In 2024, still alcohol is the number one, but you can see that cocaine has overtaken that as the number two problem drug. Opioids, number three, benzos, and then interestingly, we are beginning to see more, or before I left, I'm retired now, but before I left a couple of months ago, we're beginning to see ketamine, problem ketamine use presenting for treatment. A little bit of methamphetamine tended to be in gay men who were involved in chemsex, but not a huge amount, but there was some which there wasn't at all in 2006. So the other issue I think we've mentioned changing patterns is the number of people now in 2024 who are prescribed sedative medication. So most often things like antipsychotics, not for psychosis, but for management of anxiety, gabapentinoids, and benzodiazepines, of course, prescribed benzodiazepines, sedative antidepressants I mentioned, and gabapentinoids are commonly prescribed, most often off-label, so not actually prescribed for an indicated or licensed diagnosis, but given most often for pain, which is not related to nerve pain. So I believe all of these things contribute to our drug deaths, and I'm not sure that we are great at both not starting people on sedative prescribed medication and also getting people off sedative prescribed medication, which might contribute to their risk. Not might, which does contribute. Next slide, please. So I think it's fair to say that Generally, certainly in my neck of the woods, the MAT standards were seen to relate mostly to opioids. There are actually, there's obviously principles within the standards which apply much broader than opioids, but I think generally the feeling is that the standards are focused on opioids, which are obviously the significant, where the urgent and significant risk sits. But of course, we've now got widespread polydrug use, widespread cocaine use. We've got a tension at times between what the evidence base tells us is right for public health, so what works well for populations, with what the person who's sitting in front of us, when we're seeing someone in the community or in a residential setting, what they actually want from treatment. These two things don't always align, and that gives us a challenge of trying to support someone who might want something different from what's actually on offer. When the MAT standards were launched a few years ago, I was really interested in what the pathways out of prescribing were and how much thought had gone into that. And I was told that there was a pathway to move out of treatment, that people were quite able to go to their GP for prescribing if they wanted. There was no concept at that time that some people that wouldn't want to be on prescriptions in the long term. So as I come to, there's a problem at times with okay, where do we go beyond the MAT standards? And I think the other thing is we expect medication to do an enormous amount of heavy lifting. This is not just true for addiction treatment, it's true across the whole of prescribing, I think. But we know that there are other things that contribute to long-term recovery. Next slide. There's not been a lot of study in the United Kingdom on people who have resolved their problems, people who either through natural recovery or through support from mutual aid groups are no longer dealing with problematic drug and alcohol use. But this study is from 2008, and it looks at 108 people who had resolved their problems from heroin dependence. And the research wanted to know how they managed to stop, and how they stopped was often due to an event or being sick and tired of the lifestyle and the associated problems that their drug and alcohol use was causing, drug use, heroin use in this case, was causing them. Quite often the event was something negative. It might be something positive, like the birth of a child or a new relationship, but often it was something unpleasant happened. And then there's a second thing going on, which was the process of staying stopped. And that was very much related to relationships, moving away from using buddies and forming new relationships with pro-recovery friends and networks. And disappointingly, from my perspective anyway, as someone involved in treatment, treatment was hardly mentioned at all in the process of resolving the problems of heroin. Next slide. One of my personal beefs with the MAT standards has been in relation to my work in the rehab setting as a doctor in rehab. They only mention that the paper that launched the MAT standards gives to residential rehab is in this quote here, where it's warning of the risk of severe drug-related harm, including death. And actually, there's no evidence from Scotland's rehabs that this risk exists for people leaving rehab. I think theoretically we need to be really careful around this. The study we did at LEAP did track people who died later. We studied people for 4 years after treatment, but none of the deaths were in relation to the time of leaving rehab. So it's really, the other thing that relates to the MAT standards that gives me grief is the fact that there's two policy strands developing at the same time, one on the MAT standards and one on residential rehab, which is focusing on improved access and expansion of provision. These two pieces of policy have developed completely separate from each other, and there is no bridge between them. So we need to do better in that regard. Next slide. The work that Ruth and her team have been doing in relation to both the MAT standards work and the residential rehab work, which have been commissioned to do, suggests that we're overlooking, not just slightly overlooking, but greatly overlooking resources that are in the community. This is one of our blind spots. that there's not much support from ADPs or providers. It's what's been reported back. Obviously, I don't have a precise detail on what's happening right across the country, but this is really quite interesting that there's a resource that's maybe not being utilised fully out there. Next slide. We know also that other issues are that the medication, there's absolutely, well, there are very few people around who would argue against the use of life-saving meds as a first response to people whose lives are at risk. But there are also limitations in our approach at the moment. There's a dearth, for instance, of evidence on quality of life and prescribing. As I mentioned earlier, significant numbers of people who are currently in treatment don't want to be on medication forever, and yet there's not clear pathways at the moment to move out of opiate substitution treatment if you want to. We know that there are large groups of recovered or recovering people who've resolved their issues. Some of those have come nowhere near treatment services, some of them have been in treatment, and some of them have made their recovery through mutual aid. But there's very little research evidence on, or even interest on in these populations. We don't know how they moved out of prescribing, what risks or challenges they faced, how those risks have been mitigated, what factors were associated with them reaching their goals. And there's a bit of a blind spot here, in my view. Next slide. We do know that mutual aid can have a huge impact. This recent review of Alcoholics Anonymous, done by the Cochrane Foundation in 2020, looked at many studies, large studies, including randomized controlled trials, which found that being a member of AA was almost always more effective than psychotherapies like cognitive behavioral therapy and motivational interviewing in achieving abstinence. That being a member of AA was associated with more abstinence than people in other treatments, and there were significant reductions in health savings for mental health care for each person, over £8,000 per person. Next slide. We also know, or some of us are aware of the increasing evidence that's emerging from the impact of peers who have resolved their problems being introduced to people who are currently seeking support. Mark Litt's 2009 study of people with alcohol use disorder, this was a randomized controlled trial, so a very high level of evidence, good quality, found that just by adding one person who was sober to someone's social network reduced the risk of relapse by 27% in the following year. Now, in the community and in residential rehab, I prescribed relapse prevention medication for alcohol use disorder patients frequently, for almost everybody, because it does make an impact on reducing the risk of relapse. But if I could get anything like a 27% reduction in relapse, certainly in community settings, from prescribing, I'd be very, very happy. We can't get that kind of impact from medication and alcohol use disorder. In a much more recent Norwegian study, which looked at the impact of introducing peers in recovery to people who were seeking treatment, they saw a significant reduction in the risk of death. Can you imagine if we could introduce peers to everyone in treatment and reduce our death rates in Scotland by 36%, we would be absolutely delighted. And yet, this is happening. I'm not saying it's not happening. People are being connected up to mutual aid. Of course they are. It's embedded in the MAT standards. But I'm just wondering if we've got the focus and emphasis on it, the impact of it could be much higher than we estimate or we give credence for. Next slide. John Kelly, the American researcher, says addictions, mutual aid's the closest thing we have to a free lunch, but I think it still remains one of our most underutilized resources. Next slide. There's evidence for this. A needs assessment in 2010 in Edinburgh asks 250 service users, have you ever been to a mutual aid meeting? And the answer to that was less than 1% of them had. So these were 250 people in contact with people like me and other professionals, colleagues in the community, third sector workers, drugs workers, and yet we were absolutely rubbish at connecting them up to local mutual aid groups. And another curious thing is that mutual aid communities, as I said earlier, have received almost no interest from academics. Despite there being over 1,000 meetings a week in Scotland, it's an enormous resource that far outstrips our clinics and services, and yet it's flying under the radar in terms of its impact. So we don't know at the moment how many people are going to mutual aid and how what the impact that's having in people. Let's see the next slide. This is just an example of one of the mutual aid groups, Cocaine Anonymous. This is I've been tracking meetings in Scotland since 2003, and I think this huge rise in the number of meetings. These are meetings per week in Scotland. Currently, well, when I did this count about 3 or 4 months ago, it was 165 meetings. This is probably plugging a gap in our treatment services, which are not brilliantly lined up to support people with cocaine addiction. So there's an enormous trajectory here in terms of growth. So you might then say, well, what about the other mutual aid groups like Smart Recovery, Narcotics Anonymous, LifeRing, and so on? How are they doing in terms of growth, frequency, numbers of members, and distribution across Scotland? Well, we don't know because nobody's monitoring it. Nobody's monitoring it because I think we don't value it enough to count it or give it much of a second thought. And some people are actively hostile to the idea of mutual aid, feeling that it lacks the professionalism that we can provide in our overburdened clinics. Next slide. So I'm nearly done. What can we do to improve things? I think we need to be much broader in our vision for the MAT standards. I think we need a bridge between the MAT standards and rehab. Next year, we expect there'll be 1,000 people a year going through rehab in Scotland. We need to be nimble with changing trends. We need to exploit the power of peer support and mutual aid. We need to be open to introducing people to mutual aid at orientation when they join staff teams. We need to have it part of CPD. We need to have it on the not on the back burner, but on the front burner to have it flagged up as an important intervention which can reduce drug deaths. And we need to be measuring what we're doing and reporting it. Next slide. Some people in our treatment services do want abstinence, and that makes us anxious, especially when it's opiate dependence that we're dealing with. So we need to work out what are the risks of coming off medication. How can these be mitigated? Can we have fluid boundaries between treatment services so that if things don't go the way we expect, people can get back into prescribing services quickly and harm reduction services quickly? Those close relationships don't exist at the moment, generally between rehabs and community treatment services. Next slide. And final thoughts. I think our recovery communities are rich in resources that we are not currently mining. That one of the things which is quite difficult to introduce to people who are feeling hopeless when they present to our services is to introduce hope. That's much more easily done if we involve peers in roles so they can introduce hope in a way that professionals often can't, at least not as effectively. And let's pay more attention to our community recovery resources. Done, Ruth. Don't know how that was for time. I lost track.
Fantastic. Thank you so much. There's a couple of questions here, David, if you don't mind. I'm not going to answer all of, I'm not going to ask you all of them because there's quite a lot. But I've got two here specifically, if you don't mind. So you talked about how the system should respond and the changes that are perhaps required. In relation to the treatment of cocaine and benzodiazepine, because it requires an approach other than medicine, what do you think the system should do in relation to that? There is some concern from the person who asked the question about the requirement for psychology resource that doesn't appear to be there. So how should the system respond in relation to the treatment of cocaine and benzodiazepines?
Yeah, I mean, one of the strongest evidence-based approaches to cocaine dependence is contingency management, which is essentially creating rewards for people not to use. I'm not time to go into how that works. That requires a bit of a resource unless we incorporate just what I've been talking about. If we think, we've got a long waiting time for psychology approaches, let's say, let's connect this person to a mutual aid group like Cocaine Anonymous in the here and now. In a sense, that's a sort of contingency management system as well. You can bring the person back, ask them how they get on at meetings and so on. That's the first step. And then I think we do need, I mean, it's the sad truth is it's not likely to happen at the moment because of the financial constraints, but we do need resource to develop our systems. My colleagues in the community, when I left NHS Lothian, had massive caseloads. They were dealing with people whose lives were at risk. There was pressure to implement the MAT standards. I mean, it was enormous. To then think, you know, they need to do something else on top of that, which is very tailored around cocaine dependence. That needs more resource. The third sector are dealing with most of this stuff, and they're doing it well. I think what we could do better is that connection. And the best way to get someone to a mutual aid meeting, whether it's Smart Recovery or 12-step, is to get someone to take them along. Know where the meetings are. Go to meetings yourself to get a feel for what people are going to experience when they go there, and take them along or get a peer to take them along, and then follow it up to make sure they keep going, because these are the sorts of things that will have a big impact. Yeah,
thanks, David. And the final question, I figured I would keep this one to you, given your clinical kind of experience basis around the polydrug use that Hazel talked about. So the data's showing a sort of accumulation of substances is overwhelming that respiratory system. So are we part of the problem by overprescribing suppressants? Is the question that's been asked.
Without a doubt. I saw a question earlier on when Hazel was speaking about gabapentinoids. I think there should be very few occasions where gabapentinoids are prescribed for people with any kind of addiction, actually, but particularly with opiate addiction. If you look at a lot of the research evidence on their effectiveness comes from drug company-sponsored trials. So we know that's likely to lead to a positive bias. And the risks, I think, almost in every setting outweigh the potential benefits of prescribing these drugs. The same with antipsychotics and with sedative antidepressants. The problem is, you know, I'm saying this from a position of no longer seeing patients. When you've got a patient in front of you who can't sleep, who's racked with anxiety and needs something in the here and now, it is so easy to reach for the prescription pad and prescribe something that's sedative that you know is going to give immediate relief. The problem is the negative effect of that decision might not be seen immediately, whereas the positive will be, but it might result in a death or higher risk of death or overdose further down the line. And I think we do need to get better at not prescribing these drugs in the first place and trying to get people off them where possible to reduce the risk of death.
Yeah, thanks, David. I actually really liked your reflections about recovery not being linear, and the conversations that we have with people in recovery or peers who are supporting individuals in recovery. It's just about that actually we need a little bit, I think personally, we need a little bit more sophistication about what we mean by recovery and understanding where we are providing those different kind of layers or offers, because it feels like there's really good services out there that we've been connected to that are offering fantastic resources and services for recovery, but actually they're quite limited. So I would agree. I think there's something about how we as a system try and adapt to offer more choices in relation to recovery for the longer term. So thank you very much, David. You'll see there's a bunch of questions in the chat. If you don't mind just having a wee quick look, and we can definitely maybe get you to give us a bit of a guidance. Thank you so much. Guys, that's 5:02. So if we just break for a 10-minute break at the minute, and we'll regroup here at 5 past, and then we'll get James Docherty to come in. Thank you so much to Hazel and David so far for their presentations, and I'll see you here just at 5 past for our next speaker. Thank you so much. Good afternoon, everybody, and thank you so much for all your engagement. Just seeing the contribution to the poll is reassuring, and the level of discussion and conversation in the chat. I certainly think that we've definitely struck a chord with the audience, and everyone's really interested in understanding how we can support recovery and promote it as part of our overall response to the Drug Death Task Force. James, can I just check that you're with us, and can you open up your camera and your microphone? Hi, James, how you doing?
How are you?
I'm good, how are you?
I'm good, Ruth.
So I'm going to pass to you for your 50-minute slot, and then, as we said earlier to the audience, if anybody's got any questions, if you don't mind putting them in the chat, we'll pick up a few, and then I'll pass over, we'll ask you them at the end. James, is that all right?
Yep.
Brilliant, thank you, over to you.
Thanks, Ruth. So thanks for inviting me onto this platform to speak to a subject that I really am passionate about. So I'll be asking more questions than answering questions here. So I'm a member of, it kind of follows what David was saying. It really lit me up to hear Dr. David McCartney speaking like that, because I didn't think there was medical professionals out there in the field of addiction who had that level of insight, and because I don't meet them in the environments that I occupy. So even though I'm a professional in my own right, I'm also a person in long-term recovery, and funnily enough, I'm a member of Cocaine Anonymous. And one of the things that I want to speak about is the growth of CA in Scotland. So it's basically for a member's observation. So I've been in CA for the past 15 years, and it was good to hear David had charted how many meetings there was, because when I started out in CA, there was 9 meetings, and I knew everybody in CA, and it was good to hear David say that there's like 165. So it's national, which tells us the scale of the problem, but it also tells us the scale of how grassroots movement in a community like a people in recovery can respond to adversity. And one of the things I noticed, even during the pandemic, CA mobilised and just put everything online, and a lot of people have come into recovery through that medium as well, because obviously people couldn't get to live meetings, so they didn't wait about to get permission, they just mobilised. And what I've also noticed is that my membership in CA over the years means that I engage with, like, I've listened to thousands of hours of people's experience. I've met thousands of people, and one of the things I've noticed is that there's more doctors and professionals signposting people with primary cocaine problems to Cocaine Anonymous. And it's got me wondering, has the aid of professionals been key to CA's growth? So I think it requires some exploration and study. Why is CA so effective? Why is it grew so fast? And all I've noticed about what CA have done, CA has borrowed the literature and the methodology of Alcoholics Anonymous. So they use Alcoholics Anonymous's literature. They've not got their own specific programme for recovery. They've just borrowed AA's literature, i.e. what they call the big book. That's the nickname for their 12-step process of recovery. And they've basically only substituted the word alcohol to include other addictive drugs, and then applied the same methodology. Now, we know there's a change in drug trend, and I've also thought, I do not want to imagine a Scotland without Cocaine Anonymous when you look at the scale of the problem. But it's also recognised how this grassroots movement created this groundswell where it's just grew exponentially. And to the extent that, because of the rise in the health of the Fellowship of Cocaine Anonymous in Scotland, they've recently just won the tender to hold the World Convention in 2028. Now, that is a big deal, because no many countries get to hold the World Convention. And it was brilliant to hear David speaking about the Cochrane Review, because the Cochrane Review shows that, which is basically a systemic study, that David spoke brilliant to it, but it showed the effectiveness of Alcoholics Anonymous and a path to recovery for people. And that review also showed that it helps more people achieve sobriety than all the other traditional therapies put together. But for me, it's about, how do we recognise that all these traditional therapies can complement each other, because they're one and the same? Because one of the things about being a member of Cocaine Anonymous and the recovery process, our recovery process is explicit in telling its members that we should always be cooperating with men of medicine, and we should always be encouraging people to go to outside help, because there's other traditional therapies that can aid them in their recovery process. So we're not saying it's an either or, we're saying that CA should be done along with lots of other traditional therapies. And as a Cochrane study also highlighted, that it was 60% more effective in one of the studies and a lot of other treatments. So it also showed that it lowered, and David spoke to that as well, it lowered healthcare costs. Now ultimately that's been my experience of seeing people coming into Cocaine Anonymous who pick up the tools and who run with the process. They become fully self-supporting, and they're not relying on a dependence on any other systems and structures, and they recreate their life within that relational scaffold and that context of psychosocial support. There's a saying in recovery where they say, in here you'll find a spanner for every nut. So it's an experiential-led process. So they've got brilliant terminology for describing complex issues, and a spanner for every nut is, I find it hilarious. So what they say is that it's founded on experience. So if somebody's not got experience of navigating a particular life issue, then they'll find somebody who's got that experience. Or if it's an outside issue like needing trauma therapy or medically assisted support, they'll navigate them to the properly appointed authorities whose job it is to deal with that. And what I've found as being a member in there is that it's made up of high functioning professionals, people who are, it's not just people who have been downtrodden, who are living in socially, economically deprived areas. It's rich in social class across all the classes. And we know the drug trend is changing, and David spoke about it. One of the things I've observed over the years is that the gay community, for example, in CA, they're more likely to be methamphetamine users. And I've also looked at thinking about why the systems and services respond to the rise in cocaine use in a similar way to Cocaine Anonymous has, because Cocaine Anonymous hasn't really waited. It's just responded to the adversity with the toolkit that it's got. And do we learn from their success in providing psychosocial peer-led support? What is it they're doing that works? Because the beauty of their message is, it's very simple. They only tell people what they've done. They don't tell people what to do. And which is kind of in the theme of trauma-informed practice, because trauma-informed practice is about doing stuff with people, not to them. So they've got agency, autonomy, and self-efficacy in their own journey. And I think practitioners of various kinds who are trained to provide high-level intervention and support for individuals with, for example, alcohol use disorder. The mood music of my professional career is listening to people who have got a hard time admitting that some of the lay people of Cocaine Anonymous, Alcoholics Anonymous, did a brilliant job of helping keep people away from the harms associated with alcohol and drugs. And recognising also that is this about professional power, or are we really concerned about people's lives? And do we need to get better at bridging the gap for systems and services to the wider psychosocial support that's freely available out there in the community? Because if we get really good at that, then we would get better at receiving people for systems and services. And another thing, before I finish, is CA's effectiveness based on the humility of professionals knowing that there's no sufficient substitute for cocaine, or because currently there is no medical grade substitute treatment, i.e. medicine, for cocaine addiction. So there is a less dependence on the system. Is professional humility knowing that and saying the best modality for this individual is saying you should probably go there? And is that why my experience over the years in observation and seeing people come into Cocaine Anonymous a lot of it's been facilitated by professionals. And it's just a theory, I might be wrong. Is it because there isn't a medical grade substitute for cocaine? So there's less dependence on the system, and the system's got more humility in saying, because we can't offer a cocaine substitute, let's direct them to where these people are getting real support, real psychosocial support in Scotland. And that's very interesting. So I've got more questions to be answered than telling you what today, which will probably be music to your ears. Thanks.
Thanks very much, James. And actually, I think it's really refreshing that we've all got suggestions and things that we could do to make the system different, but none of us have a silver bullet.
Yeah,
And that's the trick, isn't it? It's like finding things that will work. Can I just ask you a couple of questions, James, that have popped up in the chat? Now, I know that you're not, here to sort of market Cocaine Anonymous, but certainly you've got, the experience around it. Could you give us a little bit more detail about how Cocaine Anonymous might support people in rural communities?
So I'm not really aware of it. So obviously I'm Glasgow based, and the furthest I've been out is Edinburgh, but I during the pandemic I was online, and the online meetings allowed me to reach further into different rural communities. And what happened is I ended up a girl who from Inverness asked me if I would take her through the 12-step recovery process. And I said, aye, but I'd need to do it online, obviously. And she said, that's okay. So I never even met the lassie until she was like a couple of years into recovery. But what happened is I took her through that process, and she didn't want to go to any services. And obviously I can't force the issue in regards to where people should go. She had a young child as well. So she's a child at 3 years of age. She was worried that social work would get involved, take her kid off her. I said, right, let's have a run at this and see where it takes us. I took her through that process, and she's since started a 12-step recovery meeting in Inverness, which is a rural community. And it's by that extension this type of work happens, because she realises that in order for her to maintain her recovery, she's got to pass on the recovery message, and the recovery message is take other people through the 12-step process, which is psychosocial in nature, but it's also restorative, and it's also therapeutic, and allows them to work out a lot of the trauma they might be navigating, but also heal interpersonal conflict in their life, like with family members, broken down relationships, etc. So that's where I've best seen it. We're getting in a personal experience of taking somebody through that process, and now she's 5 years down the line nearly in recovery, and she's taking other people through the recovery process. And I didn't meet that lassie until she was like 6 months in recovery. So modem to modem, the magic could happen. It didn't need to just be face to face.
I suppose that's really reassuring, because I know it's really difficult for remote and rural communities, partly because there's a stigma component, isn't there? If if your community are very quickly aware of your status and stuff, I think it was probably it's quite prohibitive. So it's great to hear about those opportunities.
Absolutely. And also the dynamic of she'd a kid. So when somebody gets into recovery, it has a halo effect on the family system, and the kid gets the mum or the father that nature intended you to be, which is emotionally available, socially connected, and regulated and secure. And that's prevention. That's the long-term aim of prevention. I work in prevention, so obviously I see the bigger picture. But trying to get other people to see it is part of the journey, and it's also part of the frustration, because it's not just about the individual level, it's the socio-economic level.
Yeah, of course. And so there's lots of chat, James, so hopefully you can get a chance to maybe go in there and whatever, but we'll pull it off for you anyway. But just finally, in terms of, you spoke there about your experience of supporting people into recovery and stuff like that. What is the biggest challenge for you in doing that in terms of engagement with the health and social care system?
So I think the biggest challenge is to get them to see their role in bridging the gap. So I think there's a tendency to be this bastion of defensiveness rather than seeing actually you can work together and be in the crossover, because you don't want individuals being dependent on a system for the rest of their life. You want to create interdependence, so they're relying on their own inner resources and the stuff we take for granted. And it's getting the system to believe that making a full recovery is absolutely possible. Because I know I never really spoke about my own experience and my own journey getting to recovery. If you'd have saw me in the early days, you would have thought, he's no chance. I was writ off when I was a kid, but it's that thing in recognising that relational wealth is the antidote to adversity. So the research, the resilience research, the recovery research, desistance from crime research shows us that the more healthy relationships you can surround people with, the better the outcomes, because it's that social contagion where they're getting exposed to a different type of relationship. Whereas if you're just keeping people dependent on a system, they're coming for that reason, whether it's a chemical substitute for their addiction, then are you dosing up the relational wealth in that process? That's a question the system needs to ask itself.
Yeah, thanks very much, James. And also I think one of the comments that was made earlier on was about the challenge in data sharing. So if you're trying to offer sort of advocacy for people to get access to services, and there's a couple of references to health and wellbeing for people in recovery about making sure that their health conditions are sort of managed and stuff, and that they're getting those treated and whatever. And I think we're hopeful in doing something around clarifying the data position around sharing data with services and helping people to kind of get treatment and or access to services and GPs and whatever, should they need them or when they need them throughout their recovery journey. So I think you've picked up a really important point.
Did I also add as well, one of my frustrations has been, so if people have been in, if they've been in abstinence-based recovery for a while and for whatever reason they relapse and end up back in addiction, some of them show up at the system and try to get help, and part of their it becomes a really fractured process where they're basically asking the system, please help me get back to abstinence, and the system says, no, you need to do A, B, C, D. But they're saying, I don't really want to do A, B, C, D, I just want to get back to the support that I had, and the only thing that's blocking me off of getting there is detox or rehab to facilitate that detox. And I think the system understood that once you've had a frame of reference for being in abstinence-based recovery and you end up back in active addiction, it doesn't really go away. So you've got that party that knows it's available to you. It's not like somebody new coming to a service who might need a different type of support. It's recognising that if somebody's been in recovery, they know where they can get back to, and the system needs to get better at getting them back to there, because we'll pick it up. But we're not medically trained to detox people. So the system needs to get better at supporting us in regards to receiving people.
Yeah. I really like that idea about that frame of reference, because in some ways that's the sort of the visualization of hope, is that that place exists, because before that it's quite, you know, my experience in working with people in addiction, it's quite difficult to hold on to hope. But if you've had that frame of reference, I suppose you would assume it's a little bit easier to understand that lives somewhere, it's there.
Absolutely.
Thank you very much, James. And I'm just going to sort of wind up our webinar today, folks, and on the screen you'll get a couple of poll questions, if you don't mind filling them out just before we sort of whilst we wind up. Thank you very much for all of your engagement today and your participation. Particular thanks to our speakers for taking time out of quite a busy system to share and help us understand how we might support recovery and how we might ensure that across that development of a recovery-oriented system of care, that we are thoughtful about how we can support and promote treatment and recovery and see them not as linear, and actually they're very much a continuum of care, and how we can do that really well. Thank you very much for participation. Please fill out the polls before you shoot off. It's really helpful for us to make sure that we design our webinars to meet the needs of the audience. This webinar is recorded, so we will be able to share that with you guys if you want to share it across your colleagues, and it's available on YouTube as well, so we can also make sure that it's accessible for folks that can't make it live today. We will be in touch with you with a summary of today's session, and we'll send that out through email, and it just gives you a bit of a snapshot of the discussion that we've had today and some of the sort of key takeaway messages. Our next session is to be coordinated and agreed. I think we're looking at probably the winter months for that, and we'll be in touch with you guys about what that looks like, and we will definitely use the detail that we've gathered in the polls to determine what the best subject area or the best topic of discussion will be next time round. Thank you very much, everyone, for your participation and engagement, as I've said, and please do connect with us on X or on our website, and it's #HasMattMAT. So thank you so much, and I shall see you here the next time. Thank you.